colleagues. Welcome to the 5th Annual OncoAlert Colloquium, a comprehensive review of the year's top scientific advancements organized by Tumor Group. The colloquium is made possible thanks to our partners at the European Society of Gynecological Oncology, the European Society of Surgical Oncology, the Multidisciplinary Association of Supportive Care in Cancer, and the International Society of Geriatric Oncology. We're also grateful for the tremendous collaboration from the Advanced Prostate Cancer Consensus Conference, ABC Global Alliance in Breast Cancer, the Belgian Society of Medical Oncology, KidneyCan, the GARD Consortium, and our friends at GUcast. We would like to thank Pfizer and Roche for partly sponsoring this year's colloquium, and we would like to remind you that all presentations that you will see have been made independently by presenters with no industry influence on topics or content. The colloquium is divided into 7 days. Day 1, GU Oncology. Day 2, Lung Cancer and Supportive Care. Day 3, Breast Cancer. Day 4, GI Oncology. Day 5, Gynecological Cancers. Day 6, Hematology, Sarcoma, Lymphoma, and Geriatric Oncology. And Day 7, How I Treat Cancer When Facing Limited Resources.
Hi, this is Dr. Charlene Gill. I'm a GI medical oncologist based out of BC Cancer in Vancouver, and very pleased to be providing you with this update on what's happened within the last year in the areas of esophagogastric cancers and liver cancers. These are my relevant disclosures. So we'll start with esophagogastric cancers, and I'm going to start up front with sharing with you what has changed in practice in the last year. And a lot of the data really comes from the resectable esophagogastric adenocarcinoma space. And in that arena, perioperative FLOT is now the preferred standard of care. And that's based on data we're going to review both from the ESOPEC trial, which was presented at the ASCO plenary, and then Top Gear, which was presented at ESMO. And then in the advanced setting, we learned this year that for patients with GEJ, gastric adenocarcinoma with oligometastatic disease, that there is no proven benefit to resection of limited metastatic disease, and that's from the Renaissance trial. So starting with early stage esophagogastric cancers, over the last almost 20 years, we've had a series of studies that have really reinforced the importance of a perioperative or preoperative approach in the neoadjuvant setting, starting with MAGIC, and then in 2012 with CROSS that demonstrated carbotaxol with concurrent radiation and its benefit in patients with resectable esophageal GE junction cancers. Subsequently, FLOT, 5-FU leucovorin oxaliplatin and docetaxel supplanted ECF or ECX, the MAGIC regimen, demonstrating superiority with the perioperative FLOT approach. And then NeoAegis was a randomized trial that attempted to compare the two approaches. And as we know that no meaningful difference was observed in that trial. There were some limitations with that trial, but really, we were in a state of equipoise. And that led to the ESOPEC trial, which was, as I mentioned, presented at ASCO plenary last year. And then earlier last month was published in the New England Journal of Medicine. So ESOPEC sought to answer the question of which is the superior approach in this setting of patients with resectable esophagogastric cancer. So patients were randomized to receive either perioperative FLOT, so 4 cycles FLOT surgery, 4 cycles of FLOT, versus neoadjuvant CROSS, followed by resection. And this trial included patients with adenocarcinoma. So squamous cell or non-adenocarcinoma histologies were excluded. And we're talking about patients with clinical T1 node positive or T2 to T4, potentially clinically node negative with no evidence of metastatic disease. This, as I mentioned earlier, involved tumor location of the esophagus and GE junction. So if we look at the distribution of patients, almost 400 patients randomized in this trial, and one of the endpoints was pathologic complete response, which is demonstrated here, and the PCR rate with FLOT was almost 17% versus 10% with CROSS. The primary endpoint of overall survival, as we all know, favored FLOT. So this was a positive trial demonstrating a 3-year overall survival rate of 57.4% versus 50.7% with CROSS. And this was after a median follow-up of 55 months, and that translated into a hazard ratio for survival benefit of 0.70. When we think about this trial, I think we recognize that squames were excluded. So chemoradiation remains the preferred approach for squamous cell cancers, but for resectable esophagogastric adenocarcinomas, perioperative FLOT has emerged as the standard. We know there's a limitation with ESOPEC because the cross arm did not include the option of adjuvant nivolumab. So ESOPEC was commenced prior to the data from CheckMate 577. And so how this may affect the overall survival in the cross arm, we don't know. Does that really account for the 7% difference in 3-year overall survival? To date, as we know, we only have disease-free survival benefit demonstrated from CheckMate 577. And the other thing to recognize is that while FLOT may be the preferred based on ESOPEC, FLOT is not easy. ESOPEC did not include quality of life data, and we know that FLOT can be more difficult to administer in clinic versus, CROSS in terms of what patients are able to tolerate. So I think for patients who we feel are unable to tolerate FLOT, CROSS chemoradiation still remains a meaningful option. So if we think about that perioperative chemotherapy setting, one question that did come up was, what about a TNT approach in the setting? Is there a role for preoperative radiation? And thankfully, we didn't have to wait long because Top Gear is a trial that was conceived several years ago, completed accrual over 2 years ago, and this is a randomized phase 3 trial, really trying to look at the benefit of preoperative chemoradiation in a peri-op chemo approach for patients with resectable gastric cancer. And this is a multinational study, including the CCTG, which is what I'm a part of, but led by the AGITG. This study, when presented at ESMO, also had a simultaneous New England Journal publication. And so Top Gear basically randomized patients with resectable GEJ or gastric adenocarcinoma. They had to be clinical stage 1B to 3C to either perioperative chemotherapy. And so the trial started with MAGIC as the standard and transition to FLOT versus the same plus chemoradiation, preoperative chemoradiation. And if we look at surgical outcomes and pathologic outcomes, a higher PCR rate was observed with the addition of preoperative chemoradiation, almost more than a doubling, 17% versus 8% with perioperative chemotherapy. However, with respect to the primary endpoint of overall survival, this did not translate into an overall survival benefit. Those curves are pretty much right on top of each other. 3-year overall survival of about 55% in both arms. And likewise, no benefit was seen with progression-free survival. So if we kind of think about what we've learned, I think we've already established that in resectable esophagogastric cancers, perioperative FLOT is the preferred standard of care. And some of the considerations around that trial are as listed. But in patients with clinical stage 1B to stage 3 resectable GE junction gastric adenocarcinoma, there is no additional benefit to the addition of preoperative chemoradiation to chemotherapy. Although there was increased downstaging in PCR that was observed, it did not improve overall survival. Moving to the metastatic setting, I won't belabor this too much. We talked about this a lot last year. We know that the systemic therapy management, particularly the biomarker-driven approach, has evolved in the last few years. What I'm going to talk about today, though, is kind of what is the role of surgery in the treatment of metastatic gastric cancer. And we know in other disease sites like colorectal cancer, it is recognized that there's a survival benefit for patients with oligometastatic disease. The Renaissance trial attempted to look at whether survival can be improved with radical resection of limited metastatic disease in patients with esophagogastric adenocarcinoma. So this was an investigator-initiated trial where patients with limited metastatic disease, and we'll talk about that in a moment, were randomized to either a standard of care approach with systemic chemotherapy. In this case, FLOT was the frontline treatment, versus surgery followed by FLOT after induction, 4 cycles of FLOT induction chemotherapy in both arms. And if we look at their definition of these predefined subgroups of patients with limited metastatic disease, there was presence of retroperitoneal lymph node metastases, as stated here, and or a maximum of one other organ involved. So this could be peritoneal carcinomatosis, it could be liver, it could be lung, disease that was considered potentially resectable, but Krukenberg tumors or localized bone involvement. And this trial randomized almost 140 patients. And as you can see here, the primary endpoint was overall survival, and an overall survival benefit could not be demonstrated with the addition of surgery for patients with limited metastatic disease, as was defined in the Renaissance trial. In the subgroup analysis, there did appear to be a suggestion that for retroperitoneal lymph node only disease, there was perhaps a more favorable survival observed. You can see there the median overall survival, 30 months versus 17 months. And perhaps that's an area of interest, but I think in 2025, I would have to say that at the present time, really the focus remains a systemic therapy approach, and there's really no established role for surgery in this advanced esophagogastric setting. Moving on to liver cancers, a lot has happened in hepatocellular carcinoma as well in the last year, and I'm going to try to summarize this for you in my remaining 5 minutes. So the 3 key takeaways in terms of what's been practice changing is the use of systemic therapy with TACE and intermediate stage HCC is associated with a progression-free survival benefit. And the new data really was the LEAP-012 study, which used Lenva and Pembro. And this is consistent with EMERALD-3, which was Durva-Bev that we discussed last year. The second big takeaway is that there is no benefit with adjuvant Atezo-Bev based on an updated analysis of IMbrave050. And then the third takeaway is that Nivo and Ipi is associated with a significant survival benefit in first-line HCC versus TKI therapy. And that's based on the CheckMate 9DW data that was presented in 2024. So if we look at the Barcelona Clinic liver cancer staging and treatment algorithm, I think we kind of, recognize that for patients with intermediate stage disease, TACE, for the most part, is considered the standard of care. Last year, we talked about the EMERALD-1 data, which was looking at TACE in combination with Durva or Durva and bevacizumab versus placebo, and that in EMERALD-1, a progression-free survival benefit was observed, but an overall survival benefit has not yet been reported. Last year, LEAP-012 was presented, and this was a phase 3 study of lenvatinib and pembrolizumab plus TACE in intermediate stage HCC. And so these were the sort of, again, the one-to-one randomization to a placebo-controlled trial of TACE plus or minus Lenva and Pembro. Patients had to have confirmed HCC, Child-Pugh class A, no PVT or extrahepatic disease. And the progression-free survival was the primary endpoint, and a PFS benefit was observed, a hazard ratio of 0.66 favoring Lenva Pembro plus TACE versus TACE alone. That translated into a median PFS improvement of 4.6 months. However, an overall survival benefit has not been reached. Objective response rates, again, this was seen in EMERALD-1 as well. Objective response rates were also higher by modified RECIST, 70% with Lenva Pembro plus TACE. And so these 2 trials, EMERALD-1 and LEAP-012, demonstrate a PFS benefit with the addition of systemic IO combinations with TACE in intermediate stage HCC. There appear to be no new safety signals, but the overall survival data is still pending. And I think it's arguable whether PFS is a reasonable surrogate to change practice. In my opinion, while both of these trials are consistent in terms of the direction of benefit, I think it's insufficient to change practice for all patients with intermediate stage HCC in the absence of an overall survival benefit. But this may be a consideration where downstaging is a goal given the increased overall response rate. Again, something worthy of discussion at tumor board, perhaps for patients who might potentially be candidates for downstaging to resection or transplant. Moving on to the adjuvant setting, so a few years ago, IMbrave 050 was presented and published looking at the role of atezo-bev in patients with high-risk resected HCC versus active surveillance as a standard of care. And what was remarkable this year was that the early relapse-free survival benefit that had previously been reported on more mature follow-up was not maintained. So you can see those curves came together with longer follow-up, and this is no longer statistically significant for a benefit in relapse-free survival. And I think it was a very sobering reminder of the importance of mature follow-up and how a potentially positive trial has in fact been confirmed to be a negative trial. Where do we go from here? This is a trial, the slide from the discussant at ESMO, and we recognize that there are a number of adjuvant trials which have completed accrual and are looking at immunotherapy in this setting. And so those results are awaited and will have to be kind of interpreted in the context of what happened with IMbrave 050. And then finally, in the first line setting, we know that there has been, over the last decade in particular, really an evolution of first-line treatment options for patients with advanced HCC, particularly with the emergence of immunotherapy. What I'm going to be talking to you about is the data from CheckMate 9DW, which was looking at Nivo and Ipi versus TKI therapy, sorafenib or lenvatinib in first-line HCC. And CheckMate 9DW was designed to look at overall survival with a combination of Nivo 1 and Ipi 3, so high-dose ipilimumab. And as you can see here, based on the survival curves, 9DW met its overall survival endpoint, hazard ratio of 0.79, with a median survival of 23.7 months versus 20.6 months with TKI therapy. So two things of note. The TKI therapy was predominantly lenvatinib. 85% of patients received lenvatinib. And 20.6 months is the highest sort of median survival that has been observed with TKI therapy. Previously, this was seen in LEAP-002, where a high survival was seen with the lenvatinib arm. So that's also of note. I think what's remarkable is what the story that this Kaplan-Meier curve tells us. So there is early crossover, which kind of makes us a bit concerned about was there early toxicity in patients who received Nivo Ipi, but over time there is a tail to that curve. And if you look at the 3-year survival, it's a 12% improvement in 3-year overall survival with Nivo Ipi versus TKI therapy. So longer and more durable survival benefit that's seen. In terms of thinking of immune-mediated adverse events, I think I just want to highlight that about almost a third of patients required high-dose steroids with the Nivo 1 Ipi 3 combo, and in 13% of patients, this led to discontinuation. There were also 4 deaths that were reported on the Nivo Ipi arm, which are also kind of highlighting that Ipi 3 is different from Ipi 1, and we need to be mindful of the toxicities. So in summary, when we think about the landscape of HCC, Nivo Ipi is now going to be an option in the first-line systemic therapy treatment, along with atezo-bev and the STRIDE regimen. And for those patients not suitable for immunotherapy, TKI-based therapy remains an option. And I think the 20.6-month survival seen with 9DW and the lenva arm is reassuring if we cannot give immunotherapy. In the intermediate stage, I think it's still the EMERALD-1 and LEAP-012 data is encouraging, but I think we still need to wait the overall survival data. And in early stage disease, the standard of care remains active surveillance adjuvant. There's no established adjuvant therapy benefit in those patients. And so with that, I thank you very much and look forward to any questions. Thank you.
My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, and it's my sincere pleasure to present on behalf of the OncoAlert Colloquium regarding updates in colorectal and anal carcinoma. These are the 4 primary trials I will be discussing, as well as some other updates. But let's focus on the BRAF V600E mutation. As many of you know, this is a poor prognostic indicator in our MSI stable patient population. Breakwater is a trial looking at the role of encorafenib and cetuximab, which is already approved in the refractory setting, but here in combination with systemic chemotherapy. Patients were originally randomized to one of 3 arms, encorafenib cetuximab, or the combination with FOLFOX or the standard of care. Eventually, the encorafenib cetuximab arm was eventually discontinued. And the primary endpoints were progression-free survival and overall response rate, as well as overall survival as a secondary endpoint. Here, for the purpose at ASCO GI, the focus is to focus on overall response rate and an interim analysis of overall survival. These were the patient demographics. And the overall response rate is noted here was 61% versus 40% for the control arm, with an improved duration of response as noted here. The interim overall survival was reported at 6 months, 92.3% versus 87.1%, and at 12 months, about 80% versus 66%. These results were eventually updated in a press release indicating there is an improvement in overall survival. And these were the SAEs that were noted as part of the treatment that was provided. And these were not unexpected SAEs by any means. So I would say that encorafenib cetuximab plus FOLFOX is a standard of care for BRAF V600E MSI stable patient population. There is an ongoing arm also in combination with FOLFIRI that has finished enrollment, and we are also waiting for those final results. This paper has been published in Nature Medicine. Now to focus on our MSI high patient population, the results of the nivo ipilimumab versus nivolumab as a single agent. This was presented also at ASCO GI, once again looking at the ECOG performance status of 0 to 1. These were the results that we were looking forward to hearing about. We had heard about the results earlier about nivo versus systemic chemotherapy, which demonstrated an improvement in benefit, which was of no surprise. But here is a doublet better than single agent. And basically, these are the results that were presented. These are the patient demographics as noted here. And it should be noted that, once again, it's really to focus on what other prior lines of therapy had dual primary endpoints, and the median follow-up was 47 months. As you can see here, for the combination, the median PFS had not yet been reached. The hazard ratio was 0.62. And basically, when you look at 12 months, 24 months, and 36 months, PFS was all in favor of the combination. The overall response rate was 71% versus 58% for the single agent. And the SAEs, I don't think were anything that we were surprised about, honestly, because we are very familiar with potential toxicities of the combination. So I would say nivolumab plus ipilimumab based upon CheckMate 8HW is very reasonable in the setting of an MSI high patient population. However, if you have a patient that is has a poor performance status or remains frail, pembrolizumab, I believe, is still very reasonable in that setting. Once again, the combination may not be as tolerated as well necessarily in a patient with poor performance status, and really evaluate your patient, because the combination obviously has significant benefits, but that's not to say single agent still doesn't have benefits in a certain patient population. There was also interesting data regarding the role of aspirin in locally advanced colon carcinoma. This is the Alaska trial. And this is looking at low-dose aspirin and recurrence rate in colorectal carcinoma patients with a PIK3CA mutation. This is the study design. They screened over 3,500 patients, and they noted that there were obviously some patients that had the standard PIK3CA mutation of exons 9 and 20, and then other PIK3 or P10 mutations. Patients were randomized to 160 milligrams of baby aspirin for 3 years versus placebo. And this also noted, it should be noted, also included rectal carcinoma patients. And the time to colorectal cancer recurrence was the primary endpoint. And then secondary endpoints included disease-free survival. Here is your basic data regarding the median age. 67% of patients, or 2/3 of patients, were colon cancer patients. And then the majority of patients were stage 2, although fairly equivalent for the most part. And then in regards to the rectal carcinoma patient population, the majority of patients were stage 1 and stage 2. 50% of rectal cancer patients had received neoadjuvant therapy, and 50% of colon cancer patients had been given adjuvant therapy. And these are the results regarding the primary outcome of colorectal cancer recurrence. Regarding the more common PIK3CA mutation of exons 920, you can see here the hazard ratio is 0.49 for 160 milligrams in favor of baby aspirin, 160 milligrams versus placebo in regards to colorectal carcinoma at 3 years. And for group B with other PIK3CA mutations, the hazard ratio is also 0.42. Also, once again, in favor for baby aspirin, at a dose of 160 milligrams, if I did not say that earlier. Secondary outcomes, including disease-free survival, as noted here, hazard ratio 0.61, p-value 0.91. And for the other PIK3CA mutations or P10 mutations, here, once again, hazard ratio 0.51 with a p-value of 0.17. So these findings were actually very intriguing, and obviously keeping in mind that you may want to consider utilizing baby aspirin in your patient population following the completion of the patient's therapy for both colon and rectal cancer. Keep in mind, we commonly do not test for a PIK3CA mutation. And so that is an issue that may arise in regards to coverage if you actually want to demonstrate it based upon your documentation. But this may indicate that we may be testing for PIK3CA mutations moving forward. And a baby aspirin at 160 milligrams is not unreasonable. So these are the key takeaway points. Once again, reduced recurrence rate by 50% in patients with colorectal carcinoma with PIK3CA mutations, can change clinical practice for about a third of patients with early stage disease. And then repurposing of safe, inexpensive, globally available baby aspirin, and demonstrating that we may be testing patients for the PIK3CA mutation. Quick updates on anal carcinoma. Just a friendly reminder, anal carcinoma, we do not have the most recent numbers in 2025. However, the numbers for incidence has increased in the United States past 10,000 cases per year. The majority of patients will present with earlier stage disease, and they will be treated with concurrent chemoradiation therapy with curative intent. However, there will be patients that are at risk for still failing concurrent chemoradiation therapy due to their tumor size or lymph node positivity. And then obviously patients with distant metastatic disease at presentation, we'll be discussing that further. There's a rise in annual incidence by 2.7% per year, and it's estimated the global incidence is over 30,000 cases. At last year's ESMO, there was an update regarding frontline therapy. This is the Podium 303 study, which is based upon an earlier trial called INTERACT. And basically, this is providing carboplatin plus paclitaxel at a weekly dose based upon the previous trial of INTERACT, which demonstrated improved response rate with reduced toxicities when compared to 5-FU and cisplatin. And that has created carboplatin paclitaxel as a standard of care for this patient population. This is a 1-to-1 randomization plus or minus retifanlimab, and patients were allowed to cross over in this trial because IO therapy is not considered a standard of care in the refractory setting outside of the United States. This is after a short-term median follow-up of about 7 months. They demonstrated that progression-free survival was improved for the combination of 9.3 months versus 7.4 months. And the median OS has also trended in favor of improvement, keeping in mind it is still early at this time point for the final OS to be determined. This has not been published yet. The overall response rate was 56% for the combination versus 44% for the control arm. And the duration of response, as you noted here, is 14 months versus 7.2 months. What is interesting, I think, to keep in mind is the control arm had a response rate of 44%. We had noted in INTERACT when it was a phase 2 study that the response rate was between 56 to 57%. But in fact, based upon this phase 3 trial, the response rate for the control arm was 44%. These were the toxicities that were noted. Obviously, for the combination, a little bit more neutropenia, as well as, definitive neutropenia that was noted from the combination arm, which is not unexpected. As a result, the combination of carboplatin plus paclitaxel with retifanlimab has received a Category 2B indication by the updated NCCN guidelines as of February of this year. I want to kind of remind you there are 3 pending trials regarding anal carcinoma in the United States. EA2176 was a study that I had the pleasure of leading, which is basically a 2-to-1 randomization of carboplatin plus paclitaxel plus or minus nivolumab. Correlatives included HPV circulating tumor DNA, and basically this trial has finished enrollment as of September last year. We look forward to the final results. The primary endpoint is progression-free survival. Secondary endpoints include overall survival. EA2165 was completed enrollment in 2023. We are definitely looking forward to these results. This is the consideration following concurrent chemoradiation therapy for locally advanced disease for patients with lymph node positivity or large tumor burden that of the primary tumor, placing the patient at high risk of recurrence. This was 6 months of adjuvant nivolumab, and that trial is pending final results. EA2182, which is looking at de-intensifying chemoradiation therapy for early stage disease T1 to N0 disease, looking at the role of single dose of mitomycin C during week 1, as well as reduction in radiation therapy. This also completed enrollment in October 2024, led by Jen Dorth, and we look forward to those results as well. Radiance is what is being conducted overseas, looking at the role of 5-FU and mitomycin C in combination with durvalumab. This is also providing durvalumab for 12 months in the adjuvant setting, and the primary endpoint is disease-free survival, and that has finished enrollment too. So I'd like to thank you for your attention today, and we look forward to further updates in colorectal carcinoma and anal carcinoma moving forward. Have a wonderful day, and please don't forget to encourage screening. March is Colorectal Cancer Awareness Month.
My name is Benedikt Westphalen from Munich, Germany, and it's a great pleasure and honor to participate in this year's OncoAlert Colloquium, bringing you my top research from 2024 in the field of pancreatic cancer. These are my conflicts of interest, none of which have influenced today's talk. I want to touch upon 5 topics, discussing a concept of treatment de-escalation with alpaca, the sequence study under the topic all at once. Then the question is more always better, Prodish 65, old, new targets, optimize one, and then giving you an example of RMC 6236, a KRAS inhibitor, hopefully glimpsing into the future. Starting with Alpaca by my colleague Clara Dorman, published earlier this year. So Alpaca asked the question if it was safe and effective to de-escalate treatment with gemcitabine and nab-paclitaxel after disease stabilization following an induction treatment. So overall, 325 patients were registered, 319 patients received standard of care induction therapy with gemcitabine and nab-paclitaxel. And if they were stable after 3 months of therapy, they were randomly assigned to either continue with standard gemcitabine nab-paclitaxel or alternating gemcitabine and gemcitabine nab-paclitaxel. And here I show you the first endpoint, and I believe this is quite important. with the treatment de-escalation, you didn't see an effect on overall survival in this cohort, showing that this is a safe way of going forward. Importantly, looking at treatment safety and adverse events in the group that had alternating treatment, grade 3 toxicities were less frequent. So maybe such an approach is doable in elderly patients where you first want to stabilize the disease, and then if you see that patients are responding, you can save some toxicity. And one can even think about re-escalating if there was some sort of progression on a de-escalated scheme. I want to follow up with escalation, published in the New England Journal by Alfredo Carato and team and presented at ASCO 2023, the sequence study. So in this phase 2 clinical trial in patients, again, with metastatic pancreatic cancer, patients either received standard of care, gemcitabine, nab-paclitaxel, or a sequencing concept alternating nab-paclitaxel, gemcitabine with modified FOLFOX. And overall, 157 patients were randomly assigned, and we're first looking at time to progression. And as you can see here in the sequencing arm, there was a significant improvement with a hazard ratio of 0.46 in time to progression compared to the standard of care of gemcitabine and nab-paclitaxel. Looking at overall survival, again, there was a significant benefit in the patients that received the sequencing protocol with a hazard ratio of 0.68, 13.2 versus 9.7 months. The treatment arm with standard treatment in the range that we've known for quite some time now, and a favorable outcome, albeit this is a phase 2 clinical trial in selected centers. If this holds true in the real world needs to be determined, but it gives you a hint of activity, and I believe in a disease that with a dismal prognosis as pancreatic cancer, another option. Now, a very important question in patients with metastatic pancreatic cancer that progress on FOLFIRINOX. This is a French study, Prodige 65. And the colleagues asked the question if gemcitabine paclitaxel, so importantly, this is not nab-paclitaxel, was superior to gemcitabine alone in patients after progression on FOLFIRINOX. 211 patients randomized in a 2-to-1 fashion. Arm A, gemcitabine and paclitaxel, and Arm B, gemcitabine alone. And as you can see, treatment with gemcitabine paclitaxel led to a significant benefit in terms of progression-free survival, 3.1 versus 2 months, hazard ratio 0.64, and a later separation of the curve. So some patients, those who are not progressing immediately during the first 4 months of treatment, seem to derive a benefit. However, and I find this quite important to look at, in terms of overall survival, treatment escalation did not yield a benefit. As you can see here, median overall survival 6.4 versus 5.9 months. The curves are overlapping. So this is putting up an important question. Maybe in patients that are quite significantly progressive, a more aggressive way of treatment in the second line can be administered. In those where you have a slower type of progression, and maybe significant side effects in terms of neuropathy could benefit from less intense treatment with gemcitabine alone. Again, stressing that this is standard paclitaxel and not what we would use in pancreatic cancer based on the impact study, NAP paclitaxel. Next up, new targets, or maybe old new targets. The notion that attacking CD40, a marker that is seen in macrophages, for example, could be a target in pancreatic cancer, altering the tumor stroma. This notion is almost 15 years old and was published by Gregory Beatty and Robert van der Heide in Science in 2011. There are CD40 agonists, such as mitazalimab, in clinical development, and Teresa Maracula and team reported this study, the Optimize 1, a single-arm, multi-center phase 1b/2 study combining this CD40 agonist with modified FOLFIRINOX. Overall, 70 patients enrolled, 65 patients treated, and 57 patients then included in the full analysis set. And as you can see, so this is first-line treatment, and as you can see, there is a good amount of patients receiving disease stabilization, partial response, one complete response, but quite a favorable waterfall plot. Here, we're looking at a disease control rate of 79% and an overall response rate of 51%. And what I find quite important is then looking at the median duration of response. This was 12.5 months. So this is very favorable, albeit, again, this is a small cohort of patients, and the authors state that they are aiming towards a randomized phase 3. So now I would like to take a short moment to look into the future with you, and I chose as an example one novel compound targeting KRAS. I could have chosen many, but I found the mode of action quite interesting, and there was data presented at the end of 2024 in pancreatic cancer that I wanted to share with you. So RMC-6236 is a first-in-class RAS multi-on inhibitor, and the compound itself binds to cyclophilin A, then builds a binary complex binding to activated RAS, and this in the end will then end up forming a non-covalent inhibitory tri-complex. So a very elegant way, I find, not being an expert in drug design, but a very elegant way to target a therapeutic target that was notoriously difficult to attack. At ENA 2024, there was more data being shown in metastatic pancreatic cancer. So this is dose escalation monotherapy in pre-treated pancreatic cancer patients. And to cut a long story short, in patients that had received 2 lines of therapy, we saw a median progression-free survival of 8.5 months, so very encouraging activity, which was less pronounced in patients in the third-line setting, but still 4.4 months in monotherapy, I found quite interesting. The study is recruiting And then if you look at this, an overall response rate of 29% in the second and 22% in the third line setting in monotherapy, but then a disease control rate around 90% is a strong signal that I would want to see more. That brings me to my takeaways, a very personal view from 2024. So I have shown you data on treatment de-escalation in the Alpaca trial. So alternating cycles of nab-paclitaxel gemcitabine and gemcitabine had similar overall survival data with improved tolerability, and this standardized dose reduction strategy might help to mitigate toxicities and might especially be in all elderly patients be an option in the clinic. I've shown you data on the sequence trial where we saw very favorable outcomes with the combination of nab-paclitaxel and FOLFOX over nab-paclitaxel. The caveat here, this is a phase 2 clinical trial. I hope that there is follow-up in terms of a phase 3 clinical trial, maybe in academic centers, to see if this is really an option in the clinic, because this combination obviously would be off-label in many settings. We've seen that gemcitabine and paclitaxel was superior to gemcitabine alone in terms of PFS in patients progressing on FOLFIRINOX in the second line setting now, but had no effect on overall survival. We've seen data from Optimize-1 showing that a CD40 agonist can be safely combined with modified FOLFIRINOX with promising response rates. And what I found very interesting here was the duration of response over a year. I hope that this moves into phase 3. And then based on the data that I've shown you from RMC 6236, my big hope for 2025 are the KRAS inhibitors. There are multiple agents now moving rapidly from phase 1 towards phase 3, and I believe this could really change the treatment landscape in pancreatic cancer, with more than 85 to 90% of patients being KRAS mutant. And with this, I want to thank Gil Morgan and OncoAlert for being part of this year's colloquium, and all of you for tuning in. Thanks a lot. Bye.
Okay. Good afternoon, everybody. My name is Nina Sanford. I am a radiation oncologist at UT Southwestern in Dallas, Texas. I'm happy to give this update in GI radiotherapy. So my talk is organized by disease site. Obviously, GI radiation oncology covers several disease sites. We'll kind of go over these 5 main ones. I'll go a little bit fast because we have a lot to cover in 15 minutes, but hopefully you can use these slides as reference. So let's start with esophagus G junction. So definitely the study that made the biggest splash this year was the ESOPEC trial. This is a trial for adenocarcinomas of the esophagus and G junction. Patients were randomized to perioperative FLOT versus preoperative chemoradiation. Again, these were patients with resectable adenocarcinomas. The main finding was that perioperative FLOT improved overall survival. The median overall survival was 66 versus 37 months. This just came out in the New England Journal of Medicine last week, January of 2025. A couple points to consider regarding how we interpret the ESOPEC study. The first was that this did exclude squamous cell cancers, which we think are more sensitive to radiation. If you look at the forest plot, the benefit to FLOT was more in older patients, was less in older patients, patients with worse performance status, and earlier stage patients, showing that the results of the study appear to be really driven by younger patients with advanced disease. Quality of life has not yet been reported. That's important for counseling patients. Some have pointed out that chemoradiation compliance was only about 2/3. However, almost all patients completed radiation. Chemoradiation dose, one could say, is relatively low at 41.4 gray, but I don't think the additional dose would have made a meaningful difference. Survival was worse than the CROSS trial, but patients had more advanced tumors. And the main limitation, which I do think is valid, is that these patients did not receive adjuvant nivolumab, which we know is approved for patients who complete the CROSS regimen and has residual disease at time of surgery. Top Gear was published in late 2024. This randomized patients to perioperative FLOT with or without preoperative chemoradiation. We see that preoperative chemoradiation improves pathologic outcomes, but there is no difference in progression-free survival or overall survival. A few considerations from this study were that the trimodality group did receive less chemotherapy. And then very importantly, this is really a study of gastric cancer. Only a third of patients had GE junction cancers. And you can actually see a trend of difference, treatment effect with regards to patients with GEJ cancers seeming to maybe do better with trimodality therapy versus the opposite with stroke distal stomach. That being said, with ESOPEC, the data really no longer support a standard role for radiation in resectable esophagus or GEJ adenocarcinomas. I want to comment on the SANO trial because there has been a lot of interest in organ preservation in esophagus cancer, really drawing from some of the rectal cancer data in that patients really do want to keep their esophagus. So this is a trial, a phase 3 cluster randomized trial, adenocarcinoma or squamous cell cancer. These patients are treated with the CROSS regimen, have 2 clinical response evaluations, and then if they have a complete response or randomized to surgery versus active surveillance. The primary endpoint is overall survival. With the results published thus far, we see there's no difference in survival at 2 years, and quality of life was better for patients on surveillance than who had immediate surgery. Further information we do need to know is the breakdown of squamous cell carcinomas versus adenocarcinomas. What are long-term oncologic outcomes, and is there additional morbidity with delayed surgery? That being said, my current practice for esophagus and GEJ cancers is here. In the interest of time, I'm not going to go through every single detail, but I just wanted to add that there is still a role for radiation. You can see where we consider it with a perioperative FLOT strategy, adding it to it either preoperatively or postoperatively when there are risk factors for local recurrence. It is still a standard of care for squamous cell cancers and, of course, for patients who are not resectable, who are not candidates for surgery. Moving on to liver. So the main study that came out this year was RTOG 1112. This was a cooperative trial of 200 patients who had HCC that was unsuitable for resection or ablation or TACE. They had B-Child PUA. They're randomized to sorafenib with or without the addition of SBRT, and the primary endpoint was overall survival. You can see from the table here that these patients were quite advanced. The majority had VP3 or VP4 tumors, meaning that they were involving the major vasculature, and the median tumor diameter was close to 8 centimeters. So these patients were treated with radiation. We can see that radiation improved progression-free survival. The overall survival is improved by over 3 months, but this was not significant, just missed significance with a one-sided p-value of 0.06. You can also see, very importantly, that radiation actually did not add much toxicity at all. So conclusions, I think, from this study are that the addition of SBRT to sorafenib improves progression-free survival and time to progression in advanced large tumors. Overall improvement was not significant, but numerically was 3.7 months better. And that benefit for patients with vascular invasion is the basis for the next trial, which I'll talk about in the next slide. SBRT added no measurable toxicity, and of course, the major limitation is that the control arm is sorafenib, which is no longer the standard of care for unresectable HCC. It's either atezo-bev or STRIDE. So this is the next trial that is coming down the line, should be opening later this year. This is patients with BCLC class C HCC, and they are at that stage because they have macrovascular invasion, and they are randomized to immunotherapy, either atezo-bev or STRIDE, with or without the addition of SBRT, and the primary endpoint is overall survival. So if you are in the actually or international and are a cooperative site for NRG, please do consider enrolling on this trial. Moving right along to pancreas. So the main study that came out was in resectable pancreas cancers. This was RTOG 0848. Patients were randomized adjuvantly or postoperatively to chemotherapy versus chemoradiation and stratified by several clinical factors. The main finding here was that you can see that OS and DFS for all comers was not different between chemo versus adjuvant chemoradiation. However, you can see that when stratified by node status, that in node negative patients, the addition of chemoradiation appeared to confer a later DFS or really OS benefit. And why do we think that is? Well, we think that patients who are N0 have lower risk of distant mets, so that they may benefit more from local therapy. The limitation, of course, is that they received an older chemotherapy and older radiation. So the next trial really, I think, will be considered preoperative chemoradiation for a subset of patients with resectable pancreas cancer. And throughout the cooperative groups, we're working on these studies. Let me just quickly check that this is actually recording before I go on. Yep, we're still recording. Okay, let me go back to that. Sorry about that. Make sure that we were actually recording. Okay, keep going. Okay, so I just want to give a shout out to this trial, which I have the pleasure of leading. This is a trial in locally advanced pancreas cancer, where patients get their standard 4 to 6 months of chemotherapy with FOLFIRINOX or Gem/Abraxane. And then those who do not have progression are then randomized to dose-escalated radiation versus standard of care, which can be chemotherapy observation or standard dose chemoradiation. This study is assessing if the addition of dose-escalated radiation can improve survival in patients. The primary endpoint is 3-year overall survival. The experimental arm or the experimental treatment is dose-escalated radiation with a target biologic effective dose of 100 gray, which can be accomplished in either 5 or 25 fractions. You can use different techniques for achieving that dose, MR or CT, adaptive or non-adaptive radiation. This is just showing there are different ways to achieve a dose of 100 gray, like one could get $1 via a dollar bill or 4 quarters. The primary endpoint is 3-year overall survival. Secondary endpoints are listed here. So just going back to that slide, if you are a cooperative site, this trial should open late April this year. I would really love if folks would consider opening up this trial and enrolling patients. As a part of the study, we actually also made an NRG contouring atlas, which is going to be used on the trial, but also can be used off study as well. And the rationale behind this is that radiation oncologists were contouring pancreas tumors in all sorts of different ways. And if you don't have a standard way to contour and a treatment plan, then it's really hard to rigorously assess the results. So I'm not going to go over in detail here, but this pancreas contouring atlas is out in the Red Journal and has very detailed instructions on how we might consider contouring these tumors, both on the trial and also considerations in practice, acknowledging that this is a space that we need more research in. So we have a set of guidelines for head, neck, and proximal body tumors, and then a different one for distal body and tail tumors. So if you're interested, if you treat pancreas cancers, please do consider reading our contouring atlas, and there will actually be an e-contour module on this, hopefully in the next few months. Okay, moving on to rectal cancer. I think we're actually doing okay for time because I'm talking very quickly. So really the non-operative management or watch and wait for complete responders has become very popular in the United States. The main trial that is currently enrolling is the JANUS trial, which looks at either standard doublet chemotherapy with FOLFOX or CAPOX or triplet chemotherapy with FOLFIRINOX to improve clinical complete response rates. All these patients get long course chemoradiation to 54 gray. This trial is enrolling amazingly. It was converted from phase 2 to phase 3 and will probably finish enrolling in the next year or so, which is awesome. This is the German trial. So a big question has been, we do radiation in long course versus short course. Are they both equally efficacious in achieving complete response for watch and wait? We don't have the data for that. So this randomizes patients to short versus long course radiation. Enrollment has already completed with 702 patients. We do anticipate results I believe, in 2026. This slide was taken from my colleague, Josh Smith at Memorial Sloan Kettering. I'm just highlighting that we have several trials, all slightly different in terms of their criteria and their treatments, but together there are over 2,000 patients that will really provide, when these trials are reported, information on the efficacy and safety of watch and wait in rectal cancer. I don't have time to talk about it in this presentation, but Prospect trial that came out last year, radiation omission, good to know about that trial. And then non-randomized trials, but trials looking at upfront surgery for so-called good prognosis tumors, where patients can just go to upfront surgery and then have chemotherapy depending on pathologic findings. That's for sort of lower risk locally advanced rectal cancers. Studies of brachytherapy, so actually a lot going on in the rectal space, all with the goal of maintaining excellent oncologic outcomes, but improving quality of life for patients, which I think is so important for all patients, but maybe especially because there are more younger patients with early onset rectal cancer, colorectal cancer. All right, we are actually doing good for time. So anal cancer. We don't have any new data presented. This is a so-called rare cancer, but I will just kind of go over some of the studies that are ongoing and hopefully should be presented soon. So the Plato trial is a trial done in Europe. So just to give some background about anal cancer, treatment really hasn't changed since the 1970s. The doses and the chemo regimens have kind of been the same, and that is resulting in probably under treatment for more advanced patients and over treatment for early stage patients. So the Plato trial, some parts have been presented, but I don't believe yet published, seeks to, as the title suggests, personalize anal cancer treatment by de-escalating treatment for early stage patients and then escalating treatments with higher chemotherapy, radiation doses for more advanced patients. And they have 3 different parts shown here. The DECREASE trial is a U.S. cooperative trial, an ECOG trial, for tumors that are less than 4 cm that is treating them to a lower dose of radiation and just 1 cycle of chemotherapy. That remarkably has completed accrual, and the endpoints are disease-free survival and quality of life. Hopefully we'll hear more about that trial and results in the very near future. I'm not going to go over in detail, but immunotherapy, there is signal that this could benefit in anal cancer. There are several trials assessing this at different time points. Some are recruiting, some are completed, so we'll get more information with this regard. And then trials for metastatic cancer. You know, we know that traditionally there have not been many lines of chemotherapy for these patients. So there are these 2 main trials that have actually completed accrual last year, looking at new agents in addition to the standard carbotaxol. So that should hopefully provide us some information as well. All right, what's changed in practice? Now the standard of care for esophagus GJ adenocarcinomas is perioperative float. But I hope you can see that this is still, I don't think, a one size fits all, and there are many nuances to this. I believe based on RTOG 1112, despite the limitations of the trial, that radiation is a standard of care for unresectable HCC. In rectal cancer, long course chemoradiation followed by chemo is really now the main treatment paradigm for locally advanced disease, as it allows for potential organ preservation. But again, many nuances to rectal cancer as well. That is probably over treatment for some patients, particularly smaller tumors. And then just want to give a shout out again to several GI oncology, radiation oncology cooperative trials opening in the near future. Please do enroll in these studies so that we can continue to personalize and improve our treatments for patients. And I believe that is it. Thank you very much for your attention. I don't have my email here. It's nina.sanford@utsouthwestern.edu. If any questions, you can feel free to reach out to me. Thank you. Bye-bye.
Good morning. My name is Laura Lorenzon. I'm a surgeon from Gemelli Hospital in Rome, and I also a sub-board member. Today, I'm here for the upper GI surgery session and the ESO session at the Alert Colloquium, and I will talk about these 3 big chapters, focusing on the latest article of research published in upper GI and cancer-related articles and trials, focusing on first surgical, what changed in surgical practice, what's new in surgical practice, what's new regarding perioperative care and quality of life of patients, and three, the latest trials on perioperative chemotherapy. So let's start. Surgical practice. The first study I want to talk about is actually a reanalysis of the logical trial. As you may remember, logical trial is a trial conducted in the Netherlands between 2015 and 2018-19 about the laparoscopic versus open gastrectomy for gastric cancer. So in this study, the authors analyzed the effect of the logical trial before and after the trials up to year 2021. And as you may see, the conduction itself of the logical trial was highly beneficial for improving the rate of laparoscopic gastrectomy. In particular, the rate of laparoscopic gastrectomy was 6% in 2012 and increased to 82% in 2021. Now, even though the logical trial did not affect the possibility of clinical outcome, it was recorded a beneficial effect of the use of laparoscopic gastrectomy, reaching a significant reduction over the time in overall and severe and cardiac complication after the conduction of the logical trial. The next study I want to talk about is about the ICG use, and in particular, this trial where the authors randomized patients about the use on indocyanine green without, or the not use of indocyanine in about 230 patients. As you can see, in the group that where indocyanine was used, there was a higher retrieval of nodes, in particular stations 7 and 8 in total gastrectomy, also 12A, and also for stations in distal gastrectomy like 4D, 6, and 12A. Similarly, in this other study, the authors evaluated the OSAT score, so the objective structure assessment of technical skills, in patients undergoing randomized for the use of ICG and non-ICG. As you can see here in this imaging, the total OSAT scores reported in the x-axis correlated with the nodal dissection and the total nodal dissection, meaning that the use of ICG not only increased the retrieval of the nodes, but also increased the quality of surgery. If we talk about laparoscopic gastrectomy, it's not possible not to mention the CLASS trial conducted by the Korean colleagues. And the class 7 in particular focus on the total laparoscopic assisted distal gastrectomy versus laparoscopic assisted distal gastrectomy. As the class 7 is a large trial enrolling more than 400 patients. The early research reported that the overall complication rate did not difference between the two groups, so totally laparoscopic versus laparoscopic assisted. However, the total laparoscopic group reported better functional post-operative outcomes and less pulmonary complication. Also, the quality of life was better for the patient undergoing a total laparoscopic procedure. However, the difference at several time points reduced and disappears after 1 year. Talking about mini-invasive gastrectomy procedures, and we're now talking about the phase 2 trial. Otherwise, the previous one was a phase 3 trial, but this is a phase 2 trial comparing the early results with the early and midterm survival outcomes of robotic gastrectomy versus laparoscopic gastrectomy. As you can see, the robotic gastrectomy reported improved 3 years recurrence rate comparing laparoscopic gastrectomy, and the beneficial improvement was particularly seen in the advanced T stage or advanced N stage, but overall, compared to laparoscopic gastrectomy, robotic distal gastrectomy demonstrated a non-inferiority in 3 years disease-free survival rates. In this further study, we are going to talk about the mesogastrium, investigated largely by the Chinese author from Jiaping Gang group, and finally we have the final results of the randomized clinical trial, adding the complete excision of the mesogastrium on the addition of D2 lymphadenectomy. This trial was conducted in China between September 2014 and June 2018 with patients with locally advanced gastric cancer randomly assigned to perform a laparoscopic D2 lymphadenectomy or a D2 lymphadenectomy plus complete mesogastric excision. Is a large trial where some 400 and almost 90 patients were randomized in these two groups. And as you can see, there was a beneficial rate for patients undergoing complete mesogastric excision on the addition of D2. However, even there was a statistical beneficial impact for the disease-free survival, but not for the overall survival rate. In this other analysis by the same group, the authors demonstrated that the numbers of the positive nodes reported within the perigastrium correlated with survival and was an independent risk factor for patient prognosis. Finally, for this chapter, we are going to talk about the IPAC with this other trial recently published, which is a phase 3 trial comparing the addition of IPAC on the top of cytoreductive surgery in adult patients with a gastric cancer and histological improvement peritoneal metastasis. According to this relatively large number, relatively large trial, because as regards 100 of patients, but with a stage 4 disease, the addition of IPAC did not impact overall survival. There was a beneficial impact for progression-free survival in the IPAC group, but this needs further exploration and explanation with further studies. However, IPAC was not correlated with other adverse events. In the second chapter of my talk, I'm talking about perioperative care. I highlighted in particular this trial where patients were randomized into performing an exercise rehabilitation. So the analysis before the start of neoadjuvant treatment and then before surgery. And as you can see in this graph, those who underwent preoperative exercise, rehabilitation with exercise performed better at the 6 minutes walking test at every single time point, but in particular just before surgery. In this very large randomized controlled trial, some 1,000 patients were assigned randomly in the control group, or some 500 patients in oral supplementation group. And here we are seeing the effect of the on long-term overall survival. And as you can see in this age graph, the beneficial effect for oral supplementation was in particular seen for the 4th and 3C stages. And so in patients who were at risk of frailty and malnutrition. So talking about preoperative neoadjuvant treatment, we are seeing here the results of the ATTRACTION-4 trial, which is a randomized trial evaluating the addition of nivolumab plus chemotherapy in patients with HER2 negative gastric cancer, previously untreated, previously unresected, advanced or recurrent gastric or gastroesophageal junction cancer. So as you can see here, the addition of nivolumab improved progression-free survival and confirmed the benefit of the addition of anti-immunotherapy blocker to standard chemotherapy. In this other trial, the KEYNOTE trial, some 1,250 patients were screened and then randomized in 4 arms, comparing the use of pembrolizumab or placebo in addition to cisplatin-based chemotherapy or FLOT chemotherapy. The results were recently published and showed that adjuvant pembrolizumab versus placebo improved the pathological complete response. This result did not translate to significant improvement in event-free survival in patients untreated. Finally, our very recent randomized control trial answered the question if the addition of preoperative chemoradiotherapy to perioperative chemotherapy is beneficial. In this large trial conducted on 574 patients who underwent randomization at 70 sites in Australasia, Canada, and Europe, the authors demonstrated that the addition of preoperative chemoradiotherapy did not improve overall survival as compared with perioperative chemotherapy alone in patients with resectable locally advanced gastric cancer or gastroesophageal cancer. Final slide is quite happy because so it's just my point of view. It's not based on the evidence and what I thought was practice changing in 2024. I think is the increased use of immunotherapy in gastric cancer treatment, which is in its use is increasing month by month, week by week, and I think it's going to improve again in the more in the future. Thank you very much. Bye.
Hi all, I am Jim Khan, and it's my delight to present at the 2024 OncoAlert Colloquium on behalf of ESSO. I am a professor of surgery and a colorectal surgeon by trade, and a board member for ESSO too. Let me share my screen and I will try to give you a flavor of what's happened in 2024 with regards to colorectal. I hope you can see my slides. So I'll try to summarize the few big things that have happened in 2024. And some of them you may be aware already, and some of that might be new information. These are my disclosures. I'm a passionate robotic surgeon and a keen trainer, run a variety of courses and training symposia and congresses around this. I think 2024 has been a great year for colorectal because some key innovative clinical trials have come forward with some cutting-edge research. A lot of focus has been on preoperative treatment in the neoadjuvant setting. The use of minimally invasive surgeries, in particular robotics, has been on the top of the agenda, and then some new novel technologies have been developing in the background. If you look at the preoperative treatment in the neoadjuvant setting, Foxtrot trial published its results at the back end of 2023. It's a preoperative chemotherapy for operable colon cancer, and it's a randomized international clinical trial with 6 weeks of preoperative oxaliplatin and fluoropyrimidine chemotherapy for operable colon cancer. And it showed that out of that 6 months of adjuvant chemotherapy, you can upload a proportion of that before surgery and see whether we get a better tumor clearance rates and better disease-free survival. The main concern as surgeons we all had was whether this will increase perioperative morbidity, and the trial hasn't shown that. This if successful, could change the whole paradigm as to how we manage locally advanced colon cancer. For me, this is the way to look at it. If we see stage 3 and 4 locally advanced colon cancers, they were randomized in a 2-to-1 fashion to 6 weeks of neoadjuvant chemotherapy followed by surgery, and then followed by 18 weeks of post-operative chemotherapy. And the control group was the standard 24 weeks of post-operative chemotherapy. In this study, 87% of patients were able to complete the neoadjuvant chemotherapy before surgery. We always worry about whether people develop obstructive symptoms or complications requiring emergency surgery. And there was 4.3% of those patients who required surgery, but there were fewer serious postoperative complications noted. There was a significant downstaging in tumor histologically, but more importantly, the chances of having residual or recurrent disease at 2 years was significantly less in the treatment arm. There was interestingly limited benefit in MMR deficient tumors. As you can see on the survival curves over between the control and the experimental arm, you can see a significant difference with disease-free survival. The other study which has come to light recently is a NeoPrism CRC trial, and that is investigating a very specific pembrolizumab as an immune checkpoint inhibitor as a form of neoadjuvant therapy for stage 2 and 3 MMR deficient or MSI high colorectal cancer. The idea was to maximize the chances of cure in early stage disease, to get a complete pathological response, and using tumor mutation burden as a biomarker to predict clinical response and benefit to immunotherapy. It is the first of the multi-center phase 2 trial. So far, shown as 59% had complete pathological response post-treatment with obviously a cancer-free time of 6 months. Longer follow-up is needed to see the efficacy of this regime, but there is a potential for immunotherapy to redefine how we treat neoadjuvant therapy in colorectal cancer, especially when we know the biology of the tumor in more detail. So in this study, operable high-risk tumors, stage 2 and 3, but they were MMR deficient or MSI high, were included based on the tumor burden, whether it be high or low, defined as more than 6 mutation or less than 5 mutation. 3 cycles of pembrolizumab were given, and then surgery was undertaken, and then 4 to 6 weeks of within 4 to 6 weeks of the last cycle. And in patients with low tumor burden, surgery at 4 to 6 weeks was taken after 1 cycle of pembrolizumab. The primary endpoint was again the PCR, and of course we're looking 3-year disease-free survival, overall survival, and safety and efficacy of the neoadjuvant regime. We don't have the long-term follow-up on this as such yet, but so far very high PCR rates has been observed. Robotics have been in the center stage in 2024. I think the argument between laparoscopic rectal cancer resection versus robotic rectal cancer resection has been going on for some time, since the ROLAR trial published in 2017. The big data that we published from Portsmouth comparing over 595 patients with rectal cancer resections with mid to low rectal tumor operated between laparoscopy and robotics, and with a completed 5-year follow-up, and we showed better 5-year overall survival in the robotic TME group. There were no other short-term differences. Of course, there was a lower conversion rate in the robotic group and shorter length of stay, and a low risk of postoperative complication, which did support the use of robotic approach. But the key was the better 5-year overall survival in this big cohort. Real trial from China came out and hit the headlines. Similar results were obtained comparing robotic and laparoscopic TME surgery for mid to low rectal cancers. 11 hospitals in China participated in this study with over 1,100 patients. And then the usual short-term outcomes, including length of stay, complication rate, reoperation rates were recorded. But more interestingly, the 3-year local recurrence, and disease-free survival were observed. This trial, for the first time, showed a significant improvement across all domains when comparing robotics and laparoscopy with better CRM clearance, better quality specimen, lower 3-year disease-free and local recurrence rates, and showed improvement across all domains in favor of robotic approach. The group is also preparing a REAL 2 study now, which hopefully will share its results in the coming year or two. An interesting piece of working from the US, which is a miniaturized robotic-assisted surgical device, or MRASD evaluation. I think the robotic platforms have reached their ceiling in terms of hardware. The improvement is happening in the designing of miniature robots, which can be used through very small incisions with intracavitary retractions and exposure. Of course, the safety of these devices have to be evaluated, and this is a 30-patient study having a colectomy using the MRAS device, which is a very small miniature robotic appliance. The short-term results are very supportive. Of course, we haven't got long-term data more than 1 year survival, which was looking excellent. So I think that's some area to really watch for. I think we'll see more and more innovation happening with micro robotics, with intracavitary retractions and triangulations in order to perform the same operation that we have been doing with bigger exoskeleton robots. Training has also been a focus of attention for many, and learning new ways of training, using all the available opportunities for trainees, simplifying complex procedures into smaller modules, and teaching trainees in a stratified way to learn complex procedures such as robotic rectal cancer resections have been the focus for many trainers around the world. We published some data on this. For the first time, that a procedure done by a trainee or a fellow versus done by an attending or a consultant, the 5-year survival rate, both disease-free and overall for rectal cancer, remains the same if they are taught in a modular training program. And that is a good testament of a structured training program, teaching residents and fellows the highest possible level of skills without compromising patient outcomes from cancer point of view. So this did set a benchmark for training in that. And that's an area which is very close to my heart, which is navigational surgery. I think we've been using ICG and various other dyes for perfusion assessment, for lymph node mapping, but more specific dyes are coming out, and the big attention is on this CEA targeted fluorescent imaging using SGM-101 to detect presence of sentinel lymph node metastasis or extra anatomical lymph node spread. This is still in experimental domains, but we're hoping that this will become available over the next year or two for mainstream usage in surgery. Artificial intelligence, it'll be fool not to consider that in the bigger mix of things when we talk about the biggest developments that have happened in the last 12 months. AI has really taken over the center stage, and for us in surgical navigation, tissue identification, mapping using AI technology has been the focus for many of us, and we've been investigating whether we can train computers and algorithms to identify tissue structures such as connective tissue, blood vessels, important structures, which can help a trainee or a surgeon to understand the tissue planes of dissection. Here, for example, is a rectal cancer resection, and the surgeon is now mobilizing the splenic flexure. You can see the pancreas lighting in a different color there. You can turn that mode on and intermittently turn it on to see where the pancreas lower border is, so you can incise in a very precise way. You can also see where the connective tissues are, which are taken a different color, which is kind of light blue. So you know that your dissection plane is around those connective tissues. And this is the body of pancreas that you can identify with a view to get an entrance into the lesser sac. Here you can understand that there's no need for any dye that is injected into the patient. These are the algorithms that have been trained on thousands of videos, and they can pick up clues in terms of the tissue planes if the dissection is carried out in a precise fashion, as it is the case here using a robotic approach. So this kind of technology can train surgeons, guide them through various difficult scenarios, and help them to identify key structures such as ureter, pancreas, and major blood vessels. And extended reality, I think trainees, assistants, bedside assist, and theater teams using modified glasses, which can give them a real-time 3D view as a robotic surgeon would be getting on the console, has been the focus for many. We've been looking at how the experience can be improved for all the team members to have the same kind of view, depth perception, and orientation. And that is a useful tool that can be used for teaching, education, and improving performance of your team. The last thing I say before I finish is a blood test for screening for colorectal cancer, which is the Shield blood test, and that's the kind of the dream for many of us, where you can have a blood test and be screened for colorectal cancer, not having to necessarily go for a CT colon or a colonoscopy. So this blood test checks for a cell-free DNA in the blood. It was approved by FDA in 2024, and it's been used for a significant number of patients for cancer screening, and with a good high degree of sensitivity and specificity. 83% of participants with cancer detected by colonoscopy also had a positive cell-free DNA. Obviously, the sensitivity rises as the stage of the cancer rises. And for the precancerous lesions, it does have a low degree of sensitivity. The specificity for advanced tumors remains pretty high. So I think it's a work in progress. It will probably get better. And eventually we will have a blood test which can give us a total screening. But at the moment, for stage 2, 3, and 4 cancers, this could be a quick way of screening those patients. We do need to get the confidence that we're not going to miss early stage cancers if this is the only modality used for cancer screening. So I hope that I gave you a good quick roundup of developments happening in 2024 around colorectal, and I'll be happy to take any questions. You're very welcome to come and join us on this Congress later on this year if you would like to hear more about robotics and cancer surgery. Thank you very much for your attention.
Hi there. My name is Allison Rosen. I am a colorectal cancer survivor and patient advocate, and I'm going to be providing the patient perspective on colorectal cancer updates for today's OncoAlert Colloquium. A little bit about me before we start. I am a patient policy research and community advocate, a little bit of everything. Not only am I a 12-year early age onset colorectal cancer survivor, but I've worked in oncology since 2005. I have a lot of long-term issues related to my treatment, and that's really where I got started in my advocacy. I wanted to meet other people like myself that could have open and honest conversations about what was going on. I really thought I was alone when I was in my clinic, suffering in silence, essentially. But when I met other patient survivors and caregivers, I realized I wasn't. And once they started telling my story, I realized that it was important and it could be impactful to talk about my ostomy that I live with every day, to talk about my kidney issues. Essentially, long-term survivorship is really such an important topic, and research so that other people have access to care. So my goal, working in the space, but also being an advocate, is help bridge the gap between healthcare workers and researchers and the communities they serve. For this presentation, I'm presenting as an advocate, not as someone that works in oncology. You see the two pictures of me, one in the hospital after one of my surgeries, and the other one at the top of Table Mountain taking my dream trip with my ostomy in Africa a few years ago, which I never thought I'd actually be able to do. But I can, because I'm alive today due to cancer research and the people that saved my life. So a few different things that happened in 2024 that I'm going to focus on that are important to me as a patient advocate. There's a lot more that happened in 2024, but I wanted to focus on 4 different things. And I think the first one is a blood test to detect colorectal cancer. As an advocate, I talk about screening and early detection, colonoscopy, stool-based testing, other things that exist, but there's a huge chunk of the population that's not getting screened. And the approval of the first blood test to detect colorectal cancer was huge for our space, especially in advocacy. I know other companies are working on blood tests right now, and I look forward to the day that is part of the standard of care that a blood test is included in the screening modalities that everyone has access to and does not have to pay a fortune for. Next on here is something that's near and dear to my heart, the REACT study for early age onset colorectal cancer patients and their fertility preservation. This study showed that almost 50% of patients did not have a conversation with their healthcare provider about fertility preservation before starting their treatment, which I think is so important and needs to be at that first appointment a part of a conversation, shared decision making with your provider. Just because you might have children, you might not be married, or you are married, or you're a little bit older, you still need to have that conversation about what family planning looks like long term. Third on here is a new drug combination for mismatch repair deficient metastatic colorectal cancer. I think the more we can have as far as metastatic colorectal cancer treatment and trials, the better, because there's a lot of young onset, especially patients that are diagnosed with metastatic colorectal cancer, and they're living a lot longer. So we need to have more research and more drug combinations so that they can live a long life, and quality of life is so important. Lastly on here, alcohol consumption being the third leading preventable cause of cancer in the U.S. Going to the next slide, the Surgeon General released the alcohol and cancer risk guide that shows alcohol consumption and increased cancer risk, I think 7 different cancers. And so this is so important because you take advantage, or you don't necessarily realize. We talk about food being a carcinogen, certain over-the-counter foods being carcinogens, but no one's actually published something this in depth about alcohol. And I know I've lowered my consumption of alcohol, which is usually just social, but I've lowered it because I don't want to have cancer happening again. So this is really important for the cancer space, for everyone to know about. And I'm really happy it got a lot of media attention. So moving on, again, I know we have GI oncologists, GI surgeons, radiation oncologists, and everyone within this group talking about a lot of other things, practice-changing things that happened in 2024. These are just a few that I wanted to highlight as an advocate and long-term survivor. So coming in 2025, I just got back from ASCO GI, and some of these things were brought up. There's more research being done, but ultimately, these are just, again, a few highlights. I'm sure the doctors will be talking about a lot of these more in depth, but for me, another FDA-approved drug for KRAS G12C colorectal cancer. They presented more results on the BAL therapy and the potential leaving out of chemotherapy. Bespoke CRC and ctDNA testing. There was a great debate, if you have an opportunity to go back and look at ASCO GI, about ctDNA or not. So I think that's really important to talk about and to educate the patient about. Then you have a lot of other screening tests. I mentioned other blood tests coming out, and then you also have Cologuard 2.0 and Oncodetect, which are to come in 2025. And lastly on here is Breakwater, new standard of care for another mutation of metastatic colorectal cancer. So I like to see this in 2025, this list, very short, again, just some highlights from me, but I know there are a lot more things coming out, a lot more drug combinations, and a lot more options for various mutations for colorectal cancer that I am very excited about, as well as the whole colorectal cancer community. So with that, I want to thank you for your time. And as always, I am a very passionate advocate. So if you ever want to collaborate, please feel free to reach out. You can find me on social media, send me a message on X or LinkedIn or any of the platforms, because I, as an advocate, just want to help you succeed and be the best as possible for your patients, survivors, and caregivers. Thank you so much.
Once again, our heartfelt gratitude to our partners and collaborators, and a special thank you to Roche and Pfizer for their support of the colloquium. Thank you for joining us today, and thank you for being a part of the OncoAlert community.